See you after.
Good afternoon, everybody, and welcome to Psychiatry Grand Rounds. My name is Tony Rothschild. I'm the chair of the Grand Rounds Committee. A couple of brief announcements. In order to receive credit for attending today's lecture, please complete the evaluation form. There's a SurveyMonkey link that came with the Grand Rounds announcement from Karen Lambert on Monday. Grand Rounds will remain on Zoom for the rest of the academic year, but we are planning to have Grand Rounds again in person in the fall. But as it was pre-pandemic, Grand Rounds will always be available on Zoom for those of you too far away to come in person. If you have questions for today's speaker, please type them in the chat function, and I will ask the speaker the questions at the end of his talk. There is no Grand Rounds next week on May 5th because there is the faculty retreat. The next Grand Rounds will be on May 12th in 2 weeks, and we will be having the annual Brascoli lecture given by Dr. Eric Hung, who's a professor of clinical psychiatry at University of California, San Francisco, UCSF. And the title of his talk is Caregivers, Allies, and Advocates, Advancing Transgender Mental Health. It's my pleasure to introduce Dr. Richard Ballon, who is professor of psychiatry and anesthesiology and associate chair for education and affairs and program director of the adult residency training program at Detroit Medical Center, Wayne State University School of Medicine. Dr. Ballon graduated from the first faculty of medicine, Charles University in Prague, Czechoslovakia, and trained in psychiatry at the Psychiatric Research Institute of Prague, and then again at Lafayette Clinic in Detroit. He has published widely in the area of psychiatric education, clinical psychopharmacology, has participated in the creation of the American Society of Clinical Psychopharmacology's curriculum. He's published on sexual dysfunction associated with medications and human sexuality. He serves on the editorial boards of several journals and is associate editor of the Journal of Clinical Psychopharmacology and deputy editor of Academic Psychiatry. He's also deputy editor of the American Psychiatric Association publishing books. He serves on the Prite editorial board and has served on the USMLE Part 2 Psychiatry Committee and the Vignette Subcommittee of the American Board of Psychiatry and Neurology. He has lectured widely at national and international meetings and has received several teaching awards from residents, as well as the American Psychiatric Association's George Tarjan Award and the APA NIMH Seymour Vestermark Award. His CV is very impressive. I don't know how he has time to do all this, but I counted it up. 157 original contributions, 28 case reports, 103 review papers, 192 editorials, 112 letters to the editor, 75 book chapters, and 14 books as editor or co-editor. And I'm leaving some things out because he has numerous book reviews as well. The title of his talk today is Benzodiazepines Revisited. Let's welcome Dr. Ballon.
Thank you very much, Dr. Rothschild. Thank you for the introduction, which was much longer than it was supposed to be. Maybe I suffer from graphomania. I don't know. Maybe that's the problem. I'm going to talk about benzodiazepines. It's a topic which came dear to my heart when we were having discussion with several colleagues. And we actually created the International Task Force on Benzodiazepines because we've been concerned that what's going on in psychiatry, that some classes of medications are gradually disappearing from being used. And one of them are benzodiazepines. Here's my conflict of interest. I actually don't have any potential conflict in relationship to this presentation. I'll be discussing the off-label and non-FDA approved indications of benzodiazepines. You'll see why there are some of them not FDA approved and so on. To describe the role of benzodiazepines in the psychiatric armamentarium, then explain the usefulness, especially in CL psychiatry, and also will address some of the critiques and controversies surrounding benzodiazepines. It is important to understand how did we get here. Meprobamate, which was called Milltown, it was named by a small town in New Jersey by its creator, Frank Berger, was discovered in early 1950s. And Berger actually originally worked in England, where he tried to stabilize penicillin, and he discovered some substances in that which were calming down some the rats, and then he developed meprobamate from this. He wanted to call it a sedative, but he was convinced by others that it provides tranquilization and tranquil feelings. So then they created the term tranquilizer, like a minor tranquilizer compared to the antipsychotic. Milltown, meprobamate, actually became a blockbuster drug. It was bigger than Prozac in the 1990s. For instance, there was a drink called Miltini, which was martini, but the olive was replaced by a pill of meprobamate. So that was a very popular drink at the time. The introduction of meprobamate was a very important thing because, as Andrea Tone in her book Under the Age of Anxiety wrote, it was the very first time that millions of Americans, eventually doctors too, felt it was okay to take a drug for everyday ills to feel better. Milltown actually became very popular without much marketing push because Frank Berger didn't like drug reps. He didn't allow this drug to be distributed by drug reps and so on. And it's been available for a while. Apparently, it was available in the drinking waters of some cities like Las Vegas and Los Angeles, even in 2008. Well, of course, other pharmaceutical companies wanted to get a piece of this minor tranquilizer market. Roche Pharmaceutical asked their chemist, Leo Sternbach, to develop a Me Too version of meprobamate. And Leo Sternbach was a genius chemist. And he found it boring to develop something similar. So he delved into some compounds he remembered. I think they were originally dyes. And in 1955, he discovered the first benzodiazepine. It's called diazepoxide. It became available widely in 1960. He actually developed several benzodiazepines: diazepam, flurazepam, nitrazepam, flunitrazepam, clonazepam. He was a genius. Then by 1977, benzodiazepines became globally the most prescribed medications. And they became popular not just because they were working for anxiety, but because they were used in insomnia, agitation, muscle spasm, seizures, alcohol withdrawal, so many things, pre-medication, dental procedures, and so on. And from 1960s to 1990s, they were evaluated for different anxiety and other disorders by psychiatrists, but psychiatrists have been a bit apprehensive about prescribing them because of some controversies which we will talk about later. Then in 1990s, the SSRIs arrived. And of course, the companies were interested in getting as much of the market. And so they realized that the SSRIs may work for anxiety. So they started to get approval for different use, not just for depression, but also for anxiety and other related disorders. And sometimes there's an interesting thing. If you I'm sure Dr. Rothschild remembers that fluvoxamine was the third out of 4 SSRIs to be introduced to the market, but because the company felt that the market for depression and so was crowded, they brought it as a drug which is approved for OCD. It's an SSRI like any other one, and they all work for OCD and for depression in a certain way. But due to the historical circumstances, the issue of regulatory agencies approval was really disadvantageous for benzodiazepines. Most of the benzodiazepines, with the exception mainly alprazolam, were approved prior to the arrival of DSM-3. And as you may be aware of, DSM-3 was a big change in the diagnostic classification system, because prior to that, let's say in DSM-2, there were 3 anxiety disorders: anxiety neurosis, phobic neurosis, and OCD neurosis. But DSM-3 brought us, in the later editions, panic disorder, generalized anxiety disorder. Was Don Klein who split these two. And for those, SSRIs got approved, but benzodiazepines could not, because they were out of patent and nobody was interested in paying money for any big study for the FDA approval, except for the alprazolam. I'll mention it later. So the pharmaceutical industry offered psychiatry an alternative for treating anxiety and anxiety disorders, supposedly better than the benzodiazepines. So that's how we got there. So what are the benzodiazepines' properties? They are certainly anxiolytic. They're actually among the psychopharmacological substances or medications. They are the best defined as far as action on receptors and mechanism of action, because they're fairly clear. They don't hit as many receptors as antidepressants or antipsychotics and everything. So they work for anxiety, for seizures, they help with sleep, sedative, they relax skeletal muscles. They also looks like they relax smooth muscles too. We'll talk about it. So in the Psychiatric Armamentarium, they are useful or approved, as you can see on the slide, for generalized anxiety disorder, because the anxiety neurosis is basically the DSM-2 anxiety neurosis is basically the GAD of later editions. For panic disorder, especially Paroxetine and Clonazepam. For insomnia, there are 5 of them approved for that. Seizure disorders, Clonazepam, for instance, but for muscle relaxation, anesthesia, alcohol withdrawal, and anxiety associated with different disorders. I'm going to be talking about a little bit later. They're now among the most commonly used psychotropic drugs. But interestingly, psychiatrists write less than 20% of prescriptions of benzodiazepines in this country. First, most of the anxious people are seeing in primary care. So primary care physicians prescribe it, but psychiatrists are also very hesitant, as I said before, to prescribe them. They are prescribed for somatic complaints, true somatic disease. When an anxiety is an issue, I'll be talking about it. But they are not considered, at least by psychiatrists, to be the first line treatment for anxiety disorders. So here's some literature review of the role of benzodiazepines in psychiatric armamentarium for anxiety disorders. They're effective for anxiety, efficacious too. The original evidence came from the trials or assumption that if one benzodiazepine works in certain situations, others will be probably effective too. And you know it from other groups of medications. Strongest evidence actually came from the trials of alprazolam in panic disorder. I'm sure Dr. Rothschild, like me, can remember the entire issue of Archives of General Psychiatry was devoted to results of studies with alprazolam, that I remember that issue. But there was trials before even this other benzodiazepines in anxiety disorders, which are in the literature, like comparing diazepam with propranolol, and those are early times of let's say panic, and so panic attacks and phobic symptoms responded to diazepam, but not to propranolol. But there came several trials showing that alprazolam, some of them I mentioned, in the 1988 large trials like Jim Ballinger, when alprazolam was certainly better than placebo at week 1 already. At week 4, 83% of patients on alprazolam got better versus 43% on placebo. That was a huge difference. And 50% of them were panic-free versus 28% on placebo. Then there were studies comparing alprazolam to other medications. Alprazolam was better than propranolol, equal based on the dial with Lorazepam. Those were studies by Dennis Charney and by Schweitzer. I think I was in that study. And then some comparison of alprazolam and Clonazepam by George Pessar from Cleveland Clinic. Then they were compared to in the indication for panic disorder in with other medications outside of benzodiazepine group. They were compared to, let's say, to imipramine. We were saying why to imipramine. When I was young, imipramine was actually the treatment of choice for many things for anxiety disorders. We treated imipramine in a strange way. We started at 10 milligrams a day and increased every 3 days because of the jitteriness of patients, anxious patients. But alprazolam did very well in the comparison with imipramine. Then another study by Schweitzer, 6 months maintenance study, both groups were panic-free, but alprazolam was better tolerated, better accepted by the patients than imipramine. Then there were only few comparisons of benzodiazepines with SSRIs, and that's one of the problems in the literature. There's actually interesting there are a couple of articles by the Brazilian group by Antonio Nardi and Ricardo Freire. They published, several years ago, comparison of clonazepam and paroxetine, and what they did a first an open label study, clonazepam 2 milligrams and paroxetine 40. They were comparable at the 8 weeks, and clonazepam did a little bit better. But they did actually a 3-year follow-up, and in 3-year follow-up, the clonazepam did better. And then they discontinued it for those in who got remission. And then they looked at them at year 1, 2, 3, 4, 5, 6, and they saw lower relapse rate with clonazepam at year 1 and 6. And cumulative relapse rates, you can see, was 50% in the year 1 and then 89% in the year 6. So, in generalized anxiety disorder, again, benzodiazepines were used since the very beginning because the anxiety neurosis is pretty close to what we have as GAD. So there were studies showing that alprazolam worked. It was in 1982. Then alprazolam compared to diazepam, and you can see it's only a question of dosing, because originally people said, well, diazepam is not working, but when you increase the dose, it showed that diazepam is also working for generalized anxiety disorder. Then there were some studies which tested other benzodiazepines in generalized anxiety disorder. So you can see that lorazepam is, and some of these benzodiazepines on this slide are not drugs approved in the United States. You have to realize that there are like 30 benzodiazepines all around the world. Not all of them are available here. So for instance, lorazepam, there was a Canadian study, was equal in efficacy with bromazepam. Then oral and sublingual lorazepam was equally effective. Then you can see etizolone, alprazolam, bromazepam were the same. Then again, chlorothiazepam and adenosine were working. Those are the ones which are not available in the United States. Then they were compared in generalized anxiety disorder to other medications outside again of the benzodiazepine group. There was this study comparing by alprazolam with buspirone, fairly low dose of alprazolam, 2 milligrams a day versus about 20 of buspar. This buspar, you would say the dose is pretty low. I think it should be higher. But buspirone patients failed to complete due to side effects or lack of efficacy, and alprazolam, of course, worked faster. There were studies by Feiner which compared diazepam and buspirone. Diazepam was faster, and some other ones even comparing it to low-dose antipsychotics, because we know that one of my first research studies was actually on the anxiety properties of antipsychotics. So they were efficacious and comparable to other drugs. Then this was the Carl Rickles study. Carl Rickles has done a lot of studies in this area of anxiety and depression using benzodiazepines or a lot of drug trials. So he compared them with imipramine, and you can again see imipramine, trazodone, and placebo. You can see these medications are very similarly effective. There was another study comparing diazepam with venlafaxine from 2003, again, similarly effective. And lorazepam is paroxetine. Lorazepam separated with treatment effect a little bit early. And, so there's one of the few studies comparing to SSRIs. Then in 2018, actually, there was a meta-analysis by Gomez published, which put together 54 articles, so some 56 studies on benzodiazepines, SSRIs, SNRIs in generalized anxiety disorder. And they concluded in the meta-analysis the most common forms of pharmacotherapy for adult GAD are moderately effective, with benzodiazepines being the most effective among these three groups. Carl Rickles with Reinhold in 2015 wrote The evaluation of literature suggests consistent, reliable efficacy of benzodiazepine, improving some central features of GAD, both psychiatric and somatic. And benzodiazepine elicited an early response and provided the response of care by the 8th week. It tends to be sustained through the length of the treatment. Then, actually, Offidani, this is again the meta-analysis and systematic review. This is the Italian group, is Giovanni Fava. They demonstrated that actually the meta-analysis that benzodiazepines were very similar in their efficacy to in treatment generalized anxiety or panic, to tricyclics, and they're more effective in reducing the panic attacks. This is an important thing that said comparing to tricyclic antidepressants, they couldn't include SSRIs because they didn't have enough studies for meta-analysis of comparisons of benzodiazepines with SSRIs because the companies were not interested in the time. This is another meta-analysis by Quagliato. She's another Brazilian author. She found in the meta-analysis that SSRIs have less favorable side effects than benzodiazepines in the acute treatment of panic disorder, which we probably all know. This is like when we treat patients with panic, they're very sensitive, like even with the tricyclics. When I described how we were starting the treatment with 10 milligrams a day of imipramine because of some side effect issues. Social anxiety, use of benzodiazepine in social anxiety, the literature is not as rich as with generalized anxiety and panic, but there's a couple of small studies by Bruce Lydiard at those times of alprazolam being effective, and there's some studies with clonazepam, and there are several studies with clonazepam, and again, you can see some of them as great response difference between the active drug, between clonazepam and placebo. The study of Davidson, 78 versus 20%. Clonazepam was also compared to other treatments, for instance, to CBT. They were comparable, but clonazepam was a little bit better on several measures. There was Dr. Otto, which is, I think, at the MGH. And then when compared to paroxetine, also clonazepam did a little bit better, even though none of the treatments in that study by Seeded and Denstein provided very rapid solution of symptomatology. Then in other anxiety problems, for instance, alprazolam combined with house cold is helpful in a small placebo-controlled study of patients with agoraphobia. And intranasal midazolam was effective for MRI-associated claustrophobia in double-blind placebo-controlled study. It just shows how helpful they are in different indications. So Carl Rickers then wrote something about benzodiazepines versus antidepressants in anxiety disorders, because we're not talking only about anxiety disorders, but using them also in other psychiatric or mental illness, whatever. Carl wrote that there is no evidence for the superiority of the new antidepressants over benzodiazepines, both in terms of efficacy and safety. And as far as the benzodiazepine toxicity, adverse events, and withdrawal symptoms, they're usually cited as the reason of the superiority of the antidepressant over benzodiazepines. But as Carl pointed out, the antidepressants are not better tolerated than benzodiazepines, and they cause withdrawal symptoms too. Carl is actually a very interesting man. He's almost 100 years old and he's still sharp and doing things. So now, benzodiazepines in other disorders, as I said, other than anxiety disorders. We started with some small studies, like Ira Lesser had a study showing that alprazolam relieves secondary depression. And I think it was even shown in the original studies in those archived journal psychiatry articles. So Benassi, again, that's the Italian group in Bologna, found in the systematic review of 38 studies that benzodiazepines and tricyclics were comparably efficacious in anxious depression. There's only one study which included an SSRI fluvoxamine. So they actually concluded that there's no indication that antidepressants are preferable treatment for anxious depression. But this is a very interesting concept because we, interestingly, for years, we have not been thinking about depression in terms of anxiety. If you look at the DSM editions, until DSM-5, anxiety is not part of depressive symptomatology. You can memorize those 9 symptoms and seek card or whatever. And so only in DSM-5 it has been finally attached to depression the specifier of anxious distress. But before that, anxiety was not part of depression, which is an interesting notion. So benzodiazepines are also used in, for instance, in schizophrenia, for catatonia, in akathisia sometimes, and associated anxiety because schizophrenics are sometimes anxious too, and of course, residents know in psychotic agitation. You all remember B52, Haloperidol and Lorazepam, famous combination from the ER. They are preferable for use in alcohol withdrawal. 5 of them, as I said, are approved for sleep: triazolam, temazepam, estazolam, fluvarazepam. I bet that and clonazepam, and I bet nobody remembers clonazepam, generic name Doral. They're used for GI endoscopy and colonoscopy, midazolam, diazepam to relieve anxiety and discomfort. Not only that, when I had, as an old man, my colonoscopy, I asked the surgeon, the guy who was doing it, I said, what are you going to give me? And he said, midazolam. I said, why? And he said, he looked at it, chuckled, and said, because you're not going to remember anything. And he was right. I woke up and he showed me the movie of what was going on inside of my body, and dental procedures too. Now, in psychosomatic medicine, anxiety could be a useful warning sign to help individuals to focus on potential problems. Sometimes it is something which we should not be treating. We should just pay attention to it because mild anxiety sometimes is a signal of something, but it's not necessarily interfering with functioning or just minimally. So, but a differential diagnosis of anxiety in medical illness is very important. So, what is the anxiety? Is it primary anxiety? Is it illicit or illicit or prescription drugs? Is it associated with discontinuation of some medication? You can stop some medication, people get anxious. Is it related to the medical illness, to reaction to catastrophic illness? It's an intrinsic factor of the physical disorder. Is it a context of some special medical disease or chronic disease when people are, let's say, people having cancer? So this is from Mark Shepard from a long time ago. So you have situational anxiety related to catastrophic illness. Yeah, if you have mood problems, you definitely use antidepressant. But for periods of escalating anxiety or continuing anxiety, anti-anxiety, namely benzodiazepines, may be preferable. Remember the term of anxious depression, which I also mentioned, which is coined by some people. There's some medical disorders which are, associated with intrinsic symptoms of anxiety. Mitral valve prolapse. People who have done research in the area of panic disorder may remember that at the original time of studying panic disorder, mitral valve prolapse is a big thing as far as the differential diagnosis and panic. Hyperthyroidism, cardiovascular disease, angina, arrhythmia, anxiety predicting the risk of major cardiac events in that famous study by Fraser Smith in 2008. Respiratory disease, other endocrine disease, pernicious anemia, porphyria. So all of them have some anxiety problems. Cardiac disease, post-MI, people are fairly anxious, or post-surgery. GI disorders, I'm going to talk about a little bit more. Peptic ulcer disease, irritable bowel syndrome, ulcerative colitis, they have a lot of anxiety associated. And of course, people who have asthma or some allergies can be anxious too. But not, as I said, not every situation where anxiety intrinsic to medical illness should be treated with benzos. For instance, respiratory disease, you don't want to use benzodiazepine because of the inhibition of the breathing center. For that is better using buspirone, which actually may be stimulating breathing a little bit. But the benzodiazepines have been found in treatment of many other associated disorders or whatever. The treatment of anxiety in the medically ill needs to be guided by diagnosis by the underlying medical illness, medication use for medical illness, which can be triggering some anxiety, the intensity, possible side effects, and other factors. For instance, sleep disturbances. You have somebody in the hospital who cannot sleep because of being post-surgery or whatever, pain and so on. You have to help them with sleep because it's the best, most important part in my mind many times to get better with good sleep and the healing that goes better on. In the medically ill, there are several situations that may favor the short-term use of benzodiazepine: stress related to hospitalization, medical procedures, anxiety aroused by the medical condition, especially after being diagnosed, let's say cancer. So people get anxious, they may need some help with that. But that's for short term. But can there be some benefits in the long term? That they can be. In cardiovascular disease, anxiety and depression predict greater adverse cardiac events, not just in patients with stable coronary artery disease. That's the study I mentioned, Smith or JAMA. There's not just depression which actually predicted some major events. All right. Cardiovascular disease is associated with increased likelihood of any disorders could be enrolled in 2009, and anxiety should be included in evaluation of mental and physical comorbidity, he wrote. There's more anxiety and panic disorder in people with cardiac problems. There was a Canadian study in general population. So Raffanelli and again, that's the Italian group, they raised the question, is depression the wrong treatment target for improving outcome of coronary artery disease? Which is a good question. I'm not going to say no. Actually, in 1977, Louis Lasagna, who was a famous pharmacologist, he worked for FDA and other places, noted that there was a reason to believe that benzodiazepines not only possess anti-anxiolytic effect universally attributed to them, but may also ameliorate somatic complaints affecting such systems such as the cardiovascular and gastrointestinal, in addition to conditions such as tension headaches and back pain. So, Dick Shader in 1978 observed that how physicians commonly prescribe benzodiazepines as a part of a long-term management of certain medical conditions, though thought to be adversely affected by anxiety-related autonomic system hyperactivity. So he felt that maybe it helps somehow calm the autonomic hyperactivity, so that could be helpful as that. So there have been some studies showing that the long-term use of benzodiazepine in cardiovascular disease could be helpful. It was a fairly high dose of diazepam in this study, which was published in 1976, up to 85 milligrams. It was useful after the myocardial infarction. Then some later on, decade later, there was a study when patients with stable angina received alprazolam with propranolol, and people who were receiving both of them were doing better than people who just got propranolol. So there's been a significant reduction of the duration of silent myocardial ischemia in people treated with alprazolam, in addition to propranolol and transdermal nitroglycerin in the study at the same time published. There are some other studies which are small, it's a small noise, if you like. It's working in hypertension. Then atizolam was again helping with hypertension. So there are some suggestions, but there hasn't been a great study showing basically that benzodiazepines really can help in hypertension substantially. Well, this was a study not published not a long time ago by Spanish authors, Escovedo and others, which showed that people, and they were just looking at the chart, it was not by design, but they look into charts of people who had a chronic heart failure, and who were prescribed benzodiazepines or alprazolam, diazepam, lorazepam, or metazepam. Those are drugs available in Spain. And when they checked after some time the charts and regarding the reduction of cardiac morbidity, people who were receiving benzodiazepines had 15% reduction of the risk of mortality. It may not sound such a huge percentage, but it's still something. Why is it? Well, we don't know. It's decreased anxiety, or the stress relief, help in insomnia, or the decreased allostatic load. Who knows? But it helped. It was an observational study. As far as the anxiety and GI system, GI illness, as I said on one of the earliest slides, the three gastrointestinal problems, colitis, ulcer, and irritable bowel syndrome, that may be exacerbated by anxiety. And they have multiple things. Originally, they were psychosomatic, then they discovered it's the increase of secretion or whatever things, but they are accompanied by anxiety, right? Anxiety is also common in patients with functional bowel syndrome, in unexplained GI symptoms. You can see on this slide that people in one study, when they have one unexplained GI symptom, they have a high lifetime episode of major depression, incidence of episode of major depression, panic disorder, and agoraphobia. And when they had two unexplained symptoms, the rates were even higher. But again, it was in the same study. So again, increase of anxiety in GI. There's some evidence, I look into it from animal studies that and from human studies, that benzodiazepines may relax the smooth muscle in the GI system, for instance, duodenum. All right. So long-acting benzodiazepines could be especially useful considering the changing tone of the smooth muscles, especially in the GI system. Here are some studies on that, showing some relief in those disorders. For instance, metazepam, again, it's not available anymore here, but it was better than placebo in relieving major symptom complexes of functional bowel disease, like swallowing the air, nervous dyspepsia, GI pain. And so then diazepam or lorazepam, better than placebo, relieving, again, functional gastrointestinal distress. Lorazepam and diazepam, they're better than placebo in management of chronic gastrointestinal problems which are associated with anxiety. So it seems it's working in gastrointestinal problems. But again, in more indications, we also know, we mentioned that before, that they are very helpful in seizure disorders and status epilepticus. That's the treatment of choice. They help people with chronic tension headache, though it's not necessarily the treatment of choice, but as additional treatment, I found some stuff that are helping in burning mouth syndrome. Some people are even using topical clonazepam because it exists in liquid form. And even Dr. Rothschild mentioned my interest on sexual disorders. Sorry. Not everybody realizes that the diazepam is available in suppositories. That's for the CL problem, for people who can necessarily take them orally or whatever. But they tried the vaginal suppository, using these suppositories for treat pelvic floor myalgia and pelvic pain. It was useful in that. So that's a huge thing. They may have, in the medically ill, are still in the area of CL or psychosomatic medicine. Sedation could be a major problem, so one has to be very careful selecting which benzodiazepine. For instance, in hepatic disease, you need to use oxazepam, lorazepam, clonazepam. That's because of the metabolism in liver, and so you should not be using benzodiazepine sleep apnea or chronic obstructive pulmonary disease. They could be useful, for instance, for some patients with cardiovascular disease and GI problems. And GI problems are interesting because both group of antidepressants, which we have used for anxiety, have some GI side effects. Tricyclists do a lot of constipation. SSRIs may cause diarrhea, but benzodiazepines don't. So as far as using them in psychosomatic medicine, there are results of some studies, which those small ones, which are encouraging. And benzodiazepines should be used in treatment of anxiety in patients with various medical illnesses, so namely cardiovascular and gastrointestinal ones, and they've been in low to moderate doses as a junk treatment found useful in many indications. Well, I said I was also going to talk about some controversies surrounding them. First are the side effects: sedation, lethargy, withdrawal and discontinuation syndrome, abuse potential, psychomotor impairment in especially older people, and with cognitive impairment, and the teratogenicity in some of them, like we know that we don't want to use clonazepam in the first trimester or whatever. So this is the most recent warning by the FDA, which was a black box warning, which was published not a long time ago. While benzodiazepines are important therapies for many Americans, they are also commonly abused and misused, often together with opiate pain relievers and other medicines, alcohol, and illicit drugs. They're taking measures and requiring new labeling information to help healthcare professionals and patients understand better all these things. While benzodiazepines have many treatment benefits, they also face some risks of different things: abuse, misuse, addiction, and dependence. All right. As far as the withdrawal and discontinuation, it's an interesting, again, maybe promulgated by the drug companies, I don't know, semantic confusion. With benzodiazepines, we talk about withdrawal, and withdrawal has a bad connotation. With other medications, we say, oh, it's discontinuation thing. Well, it's the same thing, all right? Many other medications have a host of unpleasant symptoms of discontinuation. For instance, some antidepressants, some steroids. This is an article by Fiametta Koshi and Guishunat, which was published a couple of years ago. This is about acute and persistent withdrawal syndromes following discontinuation of psychotropic medications. A really good review of discontinuation of withdrawal symptoms. So, syndrome of withdrawal, most of you know them. Common symptoms: anxiety, jitteriness, palpitation, heightened sensitivity. The fact is that seizures are rare. One has to realize that if you stop medication suddenly, in some medication, the seizure or whatever can happen a little bit later. Like with diazepam in 5 to 7 days. It depends on the pharmacodynamics, whatever, in pharmacology. I remember I had a patient who came to me once and said, I'm not taking the stuff you prescribed to me. I said, yeah, let's talk about it. So no, I'm not taking it. I said, okay, let's talk about how we're going to do this. She said, I'm not discussing. I already stopped that. She was on Lorazepam. I said, okay, I'll see you in a week. She said, what do you mean? I said, I'll see you in a week. You're not going to feel that well. She was back in a week because she had started to have really some anxiety. So, withdrawal may occur within 2-3 days, sometimes in these short-acting drugs. Then it's the issue of rebound anxiety and belief that medication is necessary and overreaction to somatic syndromes. Rebound anxiety, I think that issue is still unresolved, what it really is, whether it's a return of the symptomatology or not. So. And also, it's important to note that not every patient, interestingly, has a withdrawal symptom, symptoms after stopping medication. Some stuff makes the withdrawal worse. For instance, there are benzodiazepine factors, patient factors. Let's say high dose, short half-life, longer duration of prior benzodiazepine therapy, more therapy taper. On patient level, people who have panic, they have much more difficulties with stopping the medication. People have a high level of anxiety and depression. People with some personality disorder symptomatology, and people, of course, who use something else have difficulties. So how do we discontinue benzos? Well, It's demanding clinician's time, and that's sometimes the problem because people don't want to spend time with patients. And it requires some time and energy. It should be done about 25% dose reduction per week, and the first half maybe quicker. The second half of the taper should be a little bit slower. The adjunctive medications supposedly should be helping, carbamazepine, valproate, buspirone, but they really don't work in that. Not even gabapentin. Maybe people can use the benzodiazepines with longer half-life, or CBT, clinical treatment. So there's an ongoing controversy about benzodiazepines and their abuse potential and then using. So there are people who say absolutely not, and people who would say, well, we can use them. As Vladan Starcevic wrote, that the addiction specialists or clinicians treating substance abuse disorder tend to take a harsh stand on long-term use of benzodiazepines, because they perceive them as addictive, while the clinicians who primarily work with non-addictive patients with anxiety-related disorders see the good side of benzodiazepines. The whole issue of abuse is complicated. I'm not going to go through all the symptoms of sedative, hypnotic, and anxiolytic use disorder in DSM-5. It's taken from that. You can see the symptom, the following criteria: sedative, hypnotics taken for a longer period of time. There is a persistent desire, and so on. So this, you can read it in the DSM. But there is an important thing which people not necessarily realize. Speaking of tolerance, which is defined in DSM as the need for markedly increased amounts of sedative, hypnotic, and anxiolytic to achieve intoxication or desired effect, and markedly diminished effect is continued use of the same amount of sedative, hypnotic, or anxiolytic. As it says in DSM, this criterion is not considered to be met for individuals taking these drugs under medical supervision. So it's for these people who abuse it or whatever. So similar with withdrawal, it says this criterion is not considered to be met for the definition of dependence or whatever, if the patient is under medical condition. You can see the prevalence of this disorder of dependence or whatever is fairly low. So this is language not exactly taken from the DSM, but it says that the clinically use of appropriate use of these medications, including benzodiazepines, according to a physician direction for legitimate medical indication over the extended period of time, even if physiological signs of tolerance or withdrawal are manifested, many of these individuals do not develop symptoms that meet the criteria for sedative, hypnotic, or anxiolytic use disorder, because people are not preoccupied with obtaining the substance, and its use doesn't interfere with their performance or social stuff. I'm not saying that this disorder doesn't exist and it couldn't be a problem. I'm saying that it needs to be properly diagnosed within clinical context. As again, Dick Shader, who I quote for the second time, wrote, since benzodiazepines cure neither anxiety nor insomnia, symptoms recurrence can be anticipated after discontinuation of the drug. It's understandable. We treat something, we are not curing people to that, all right? The issue of consideration of treatment versus cure is really very important in psychiatry, and let's really pay enough attention to it. Occasionally, they've been taken for, benzos have been taken for recreational purposes, often in high doses. But there's a research in primate. This is taken from an APA task force book, which I actually stole when the institution where I worked used to be closed. I went to the library, I got this little book. And that's an interesting little book published by the APA. And it says there that the reinforcing effects of benzodiazepines are considerably weaker than those of other drugs of abuse, such as sedative, hypnotic, stimulants, and opioids, all right? But they're a little bit stronger than reinforcing effects of chlorpromazine. As a class of drugs, they're not frequently taken alone for recreational purposes. The most frequent abuse of them is injection of high doses for recreational purposes, is a part of a pattern of multiple drug abuse. Among drug abusers, they may be taken by people who have a history of other drug or alcohol abuse. They can be taken with a little bit of euphoria and effect, but I don't see that. I haven't seen it myself that much. They're taken by opiate abusers. That's the problem which we have, because that could be a deadly combination, and we have to be very careful about it. So cocaine abusers use them to ease the crash. Alcohol abusers may use them. And there's some individual differences. Some people use Haloperidol and Lorazepam because they're more reinforcing. Other benzos are less reinforcing. So we'll skip through that. Again, because I know that I'm getting close to the end. I want to make sure when you talk about the tolerance and dependence, all psychiatric drugs, if taken more than a brief period of time, may produce discontinuation signs and symptoms. So physical dependence at a therapeutic dose is not a major clinical problem, again, from the task force report. At Silverman, some of you may know, it's in Bostonian, wrote that most long-term benzodiazepine users tend to decrease dosage over the time. They take less than prescribed. Those are people without substance abuse. Some people successfully withdrawn from benzos have recurrence of their anxiety symptoms. So chronic use of benzodiazepines may be useful for long-term use. This is again saying that from the task force that most non-medical supervised use of benzodiazepines involves the occasionally or intermittent use of therapeutic dose for symptomatic relief that is not associated with escalation or high dose use. The recreational use of benzodiazepines alone is uncommon. And there are differences between different benzodiazepines as far as their abuse potential. A little bit more safety stuff. Benzodiazepines are fairly safe in overdose up to 30 times the normal daily dose. That people get sedated, drowsy, and ataxia. It may lead to the respiratory depression with other CNS depressants, alcohol, and others. Treatment is gastric lavage, forced emesis, and assisted ventilation. They have additive depression, CNS depression abilities in combination with barbiturates, opioids, other CNS depressant. I'm not going to go through this POA 450. Do not combine benzodiazepines with opioids because there's an increased risk of fatal overdose. It came originally from the North Carolina study, which led to black box warning based on the result of this study. There may be occasional exceptions to this rule. It's interesting because I see some patients who are on a little bit of benzodiazepines and opioids, but you have to collaborate with the pain physicians very closely. And interesting saying, many times we ask people, give people choice. You say you can either take opioids or benzodiazepines. You cannot take both of them. Frequently, people say, okay, I want to stay on the benzodiazepine. It's interesting. We know that they are associated with high risk of falls in the elderly, but it's similar association in lesser degree with antipsychotics, antidepressants. There was the study which was showing the association of benzodiazepines use in the elderly with Alzheimer's disease. They came from Canada, but association doesn't mean it's causality. And then there was fairly a recent study, nested case control study from Denmark, which is an American Journal of Psychiatry. This study did not reveal any association between the use of benzodiazepines or Z-drugs and subsequent dementia, even when exposure were accumulated or divided into long and short-term acting drugs. Some results were even compatible with protective effects. There is some cognitive impairment with benzodiazepines elderly, but it's not associated with dementia. Now I have at the end some words of wise men. Shader and Greenblatt wrote in 1983 that in the era of personalized medicine, the ultimate decision to prescribe benzodiazepine derivative or any other medication should be based on the assessment of the patient's degree of emotional distress and level of functional disability, the potential hazards of non-treatment in relationship to the probable success of pharmacological treatment, and the hazards of the medication. They added, that the duration of benzodiazepine treatment should be tailored to the character of the underlying illness. Patients with intermittent symptoms or symptoms that are triggered by identifiable anxiety-provoking situations are candidates for intermittent therapy. Who have persistent symptoms and unremitting symptoms may require more continuous treatment, but the appropriate duration of therapy has not been clearly established, and it's still the same 30 years later. And a couple more things by Jerry Rosenbaum. Some of you may know him. He was the chief editor of MGH, and he wrote a couple short pieces. One of them is the American Journal of Psychiatry. He said the efficacy of benzodiazepines is well established, but based on the current practice of many more recently trained physicians, these medications reduce anxiety for the physician themselves by their refusing to prescribe them. He raised the issue, but what's better, whether the patient remains anxious and doctor is not, or vice versa. He also wrote in the same piece, benzodiazepines are medications such they are intended to be prescribed by those trained in how and when to use them and how to weigh the risk and benefits. They're also intended to be prescribed to address suffering, distress, and functional loss from psychiatric symptoms and disorders. As is many tools available to clinicians, they're imperfect but potentially beneficial. And another piece in Focus, he compared it as an interesting comparison. It's my last slide, I think. He said that fear biology is analogous to the immune system to protect people from external threats, then acute and sustained anxiety is like an autoimmune disorder, where the response is inappropriate, sustained, disabling, and associated with life-shortening consequences. And he said the dysregulated protective response becomes the biological threat. And in that sense, benzos are like prednisone for autoimmune disease, for anxiety. So there's a nice comparison. So thank you very much. I think I made it on time, and we still have a couple of time for some questions, Dr. Rothschild.
Yes, thank you very much. Very interesting, and a reminder to everybody to type questions for the speaker in the chat. We have a few of them. From one of the residents, would you generally wean or discontinue benzodiazepines on hospitalized patients who have been prescribed scheduled everyday dosing? I often see patients on standing Ativan for generalized anxiety.
You mean if the patient gets admitted to the hospital, for whatever reason, should they be discontinued? No, because things are going to get worse. And if you're a resident, you're being called, in the middle of the night that the patient is anxious or cannot sleep and everything. I would not. Again, depends on the clinical situation. If there's no good reason, or somebody else, some other specialty says this should be stopped, then I wouldn't do it.
Okay, we have a question from a faculty member. You may have missed the point you were making about tolerance. Clinically, a big problem he sees is the use of benzodiazepines is the tolerance that develops, not in the sense of worrying about addiction, but in the sense that the effectiveness in the short term has not been maintained over the long term without continually increasing the dose.
I don't know. I have not seen that. I have people who've been on stable dose of, for instance, Lorazepam for many years. It's possible. The tolerance develops usually to the other effects, not to the anxiolytic effect, but it develops to sedative effects and other things. But as long as it's under the control of the physician, and unless the dose gets, beyond what one usually would use, they depend on each benzodiazepine separately. I wouldn't worry. Sometimes you have to increase the dose. Maybe that the initial dose was too low. I've been in a situation where people are under treatment, and it's not just with benzodiazepines. Like when I see sometimes the faculty prescribing buspirone 5 milligrams 3 times a day, I'm like, this is nothing, and why 3 times a day, and why just 5 milligrams 3 times a day? The dose has to be higher.
Related to the long-term use, faculty member asks, other than tardive dyskinesia or chronic akathisia, are there any conditions or psychiatric disorders for which long-term or maintenance treatment with benzodiazepines is indicated? The question is particularly relevant given the accumulating evidence of long-term benzo use with cognitive impairment in later life. Well, you addressed that. that's,
Yeah, I understand. It's not associated with dementia. In older people, yes, there could be cognitive impairment, and then one has to gradually try to stop the medication.
another faculty member says the discontinuation from SSRIs is not as potentially dangerous as that from benzodiazepines. Is the relative low level of development of tolerance from benzodiazepines enough to consider this as a class of medications for long-term treatment of anxiety?
I'm not sure if I can say that the discontinuation of benzodiazepine is much more dangerous than discontinuations from some of the other antidepressants. If it's done properly, that's the problem which we have. You know, we don't want to teach residents and learn that things should be done slowly. Physician should spend time with the patient, do it gradually. If the withdrawal is done properly, I don't think it's dangerous. I can tell you, several times I stopped venlafaxine, and I had a patient with whom I was working 3 to 4 months before we were able to stop it, because he had so many difficult, withdrawal symptoms.
So Dr. Yonkers wanted to point out that the older long-term studies did not show dose escalation, and the dose settled around 2 to 3 milligrams of alprazolam per day.
Yeah.
Yeah. I mean,
I'm not using these sky-high doses of alprazolam. I don't use alprazolam that much. I use clonazepam, lorazepam, and occasionally alprazolam when people come from some other physician and they already on it.
yeah, I think that, the take-home message is that these medications do help people. You just have to use them in the right circumstances.
Exactly.
Yeah.
But we have, in psychiatry, we have several groups. You and I talked about that, of medications which slowly disappear from our armamentarium. My worry is that we ultimately end up that psychiatrists prescribe SSRIs and second-generation antipsychotics, which doesn't make us any different from primary care physicians.
Right. I've made that point as well. Right. Well, listen, thank you very much. And we'll see you at the resident seminar in a few minutes.
Yeah. Thank you. Thank you, everybody. Thank you for listening to me. Take care. Have a good one.
Thanks, Rich.
Thank
It's
you.
terrific.
Thank you, Kim. Take care.